Hello. Welcome to the Senior Rehab Project, the podcast for the community of rehab clinicians working to advance care for older adults. I'm your host, Erinn, and this is the SRPrereqs segment. In today's episode, we are going to discuss a Phase 1 randomized clinical trial of evidence-based pragmatic interventions to improve functional recovery after hospitalization in geriatric patients.
Great. Hey, Tali, how are you doing today?
I'm great. How are you doing, Erinn?
I'm doing quite well, thanks. Just enjoying the beautiful rain out here in the Pacific Northwest.
Perfect.
Yeah, so today we're going to talk about an article that was published in the Journal of Gerontology in March 2019. The title is A Phase 1 Randomized Clinical Trial of Evidence-Based Pragmatic Interventions to Improve Functional Recovery After Hospitalization in Geriatric Patients. So it's a clinical trial, Phase 1.
Okay, can you, because it was a long,
yeah,
because I think I lost you at geriatric.
Oh, well, that's good, because that was the second to last word, so you're fine.
Oh, okay. No, but if you can explain a little bit, like in your own words, what is it about?
Sure. So it's a Phase 1 clinical trial. So it's just at this one particular hospital in Texas. And they picked these 5 different interventions to look at functional recovery after hospitalization in older adults. So,
okay,
yeah.
Cool. Now I understand.
Yeah.
I understood before too, but I kind of, you know how I like when people use simple words.
Oh, definitely. And you know what? I thought I described it better than the title. So
you did.
Thank you. So this was performed at the University of Texas Medical Branch. I think 4 out of the 5 authors are from there. They work there. Another one is from Arizona State University. And what I really liked about this article was that it's got a pretty innocuous title. Like you were so bored you didn't really. You're like, oh, I need you to go over that again.
It's a boring title. Something about geriatric in Texas and Phase 1.
Yeah, exactly. But it's got some really interesting results with lots of caveats and asterisks that we'll go over in a bit. So Are you ready for the introduction?
Of course.
Beautiful. So when older adults are admitted to the hospital, things generally aren't going to be great for them. As we know, their risk for falls, their risk for losing their independence, and their potential placement in a setting with increased levels of care increases. And they're also more likely to go back to the hospital and or die. True?
True. Unfortunate, but true.
Right. So the reasons why this sort of thing happens are pretty varied. In general, older adults are moving less than usual. They aren't eating so well, and they're getting crammed full of medications. So all of those factors, plus a hospitalization, can really lead to some pretty crappy results.
True.
So
also, they are more prone to pressure ulcers, urinary tract infections.
Absolutely, yeah. Their skin it gets thinner as we get older. When anyone doesn't move and is in the hospital for a while, they're at increased risk for UTIs, and that can just cause some terrible stuff. Yeah. So right now, evidence-based interventions for recovery in the acutely ill older
Freudian slip.
Acutely ill older adults, they aren't that great. I mean, maybe more protein, maybe more exercise, maybe get them on some roids. Who knows? So these are more likely to help the sicker folks than the healthier ones, these sorts of interventions. The problem with the evidence that's currently out there for these interventions is that it's not very generalizable. They only look at populations with specific diseases or conditions. So this study looks at protein supplements, intensive PT, or testosterone given after discharge from the hospital. And they look at the effects on physical function, body composition, and their readmission 30 days post-discharge. The goal of this study is that this will be a precursor to a larger multi-center study. So that's pretty much it for the introduction, the meat and potatoes. Any questions? Any thoughts?
So what was the populations, just general population admitted to this Texas hospital?
So it was, I'll go over the inclusion criteria and methods if you like. But yeah, that's pretty much it.
Go in whatever order you want.
Oh, I will. So all of the data was collected from the University of Texas Medical Branch. Some of the methods came from a paper that they referenced, which I found. So I don't know. I get why they do that. It always just annoys me to be like, really? I have to find another paper to find your methods?
Yeah, that's I don't like it when they don't put it as an addendum.
Yes.
And I don't know if it's a copyright kind of thing. Maybe I think that's maybe the issue.
Oh, that would make sense. But it's just so annoying when I don't have institutional access, and I have a hard time getting these papers anyway, to be like, now you got to get this one.
Yeah.
Especially because like the methods are so important, they can make or break a paper.
I kind of want to know how you did. You know what? The whole way of me knowing if the research is reliable or not.
Methods.
It's like 60% look at the methods.
Yeah, absolutely. Same. Like I need to see what they're doing and why they're doing it.
Yeah.
So I found the paper. Thankfully, I was lucky and was able to access it.
Okay.
So the inclusion criteria were that these were patients that were admitted to the hospital with an acute onset of a disease or a condition. That's the verbiage that they used. They were living at home before and after hospitalization, which makes it not super generalizable. As someone working in a SNF, it's like, well, this doesn't tell me much about my population.
I know, but to be fair, it's gonna sound horrible. I'm gonna sound horrible, so I
can't wait.
I'm thinking about maybe not saying it, but there's something about knowing that a patient came from home, and my goal is to restore this ability of them living at home, as opposed to someone coming from, you know what? A nursing home is always the last stop.
Yeah, that doesn't sound horrible at all. You're just being accurate.
Sometimes there's a hospice after that, but it's usually the last stop as a living person.
Mm-hmm.
And I kind of want, I feel it's almost like a noble cause to prevent that. So I do like that they did say, listen, there's gonna be room for more research about that. Currently, we think that this is the population that we can save.
That makes sense. And I mean, there's going to be a bigger push for shorter SNF stays coming up, coming with the changes that are happening in October. So there's going to be more of a shift towards the home health side anyway. So this is relevant to our home health friends. This is relevant to our acute care friends and even our SNF friends. People go home.
I feel that it's also important for our outpatient friends.
Yes. Yeah. You're right.
As I recently became an outpatient friend.
Oh, hello, outpatient friend.
Thank you. I just today changed jobs.
Congrats.
Thank you. But it is like, an outpatient sometimes do the follow-up.
Yeah, absolutely. And even in this population, there were some people that did go to outpatient PT. They didn't mention how it affected their results, but we'll get into that in a little bit. Okay?
Okay.
Cool. So another inclusion criterion was that the patients had a self-reported ability to walk across a single room with or without an assisted device. They did not specify how big. Are they talking about a bedroom or a ballroom? I don't know. And it was self-report as well.
I assume it's not a ballroom, but I see your point.
Right? It's a room. So then they needed to have the ability to stand independently at baseline and have no problems wearing an ankle strap, which they called an activity monitor. But I honestly assume that like the participants in this study, all their friends thought they were alcoholic or something because they had the ankle monitors, or like in jail, and like instead of going to the hospital, they actually went to jail. Now they're out on bail.
But imagine how this fights ageism. Because like, man, she's a badass. At 76, she robbed a bank, and now she's on house arrest.
That's right. Nice work, researchers. So then two more criteria. They needed to be greater than or equal to 65 years of age. And the last one is that they need to be within 30 miles of the hospital. So this hospital is in Galveston, Texas, which is it's like a little, like, it's not, I think it's an island, or it's just like this little strip of land in the ocean, but it's like technically outside of Houston. So I looked up the interesting facts about Galveston to see what we were dealing with as far as population. There are about 50,000 people that live there, and they're mostly white. So I'm really glad that the researchers are like, we want to do a multi-center study because obviously if they're going for generalizability, Galveston, Texas maybe isn't the best. It's coastal. It seems to be a pretty big tourism area. Yeah.
Ooh, it seems really pretty. Sorry, I just.
Oh, I'm
Googled,
sure. Oh, you did?
I just Googled it because I have no idea where it is. It's really pretty.
Yeah, it's a big tourist area. So these are people who can afford to be there, to live there. So they actually mentioned in the results that the majority of people were pretty educated. Almost everyone had a high school degree, and well over half of them had a college degree as well.
Okay.
So, exclusion criteria. They could not be a nursing home resident or a hospice patient. They could not have uncontrolled blood pressure. They could not have a history of stroke with motor deficits. Their kidneys needed to work, and they specified the GFR and things like that.
So the acute condition cannot be kidney failure.
Correct. Yeah. And that's why this is because they're going to be having protein supplementation. And if their kidneys aren't working, that's not going to go well.
That's smart. Wow. Okay. That's good.
Yeah. They could not have liver disease because testosterone is metabolized in the liver.
Testosterone, yeah.
They could not have a recent treatment with anabolic steroids, recent being in the previous 3 months. They could not have a planned or elective hospitalization within 30 days of discharge. So if they had a knee replacement scheduled, they couldn't do the study.
Yeah.
They couldn't be determined to have cognitive dysfunction. And they figured this by chart review, a report from the nursing staff, or some sort of observation from the trained research staff. And they looked at things like alert and oriented status. If they have dementia, if they had delirium during their hospital stay, they were excluded. If they lived greater than 30 miles from the hospital, or any other condition or event considered exclusionary by the principal investigator or the treating physician. And then in the testosterone group, they couldn't have a history of breast or prostate cancer, have any palpable prostate nodules, or have a PSA of greater than 4, hematocrit greater than 50%, or decompensated heart failure, because the testosterone would really mess those things up.
Yeah.
Potentially bring that cancer back. No thanks.
Yeah, you kind of don't want this.
No. So that's all from the paper that they referenced, which that seems pretty important to me. I want to know the population that they're looking at 30 miles outside of Galveston. That's pretty significant. So then this is back to stuff that was included in the paper. They had 100 patients over 65 years old that were admitted to the hospital for acute medical illness. They had 5 post-hospital interventions. The first was supplements, whey supplements. It was 20 milligrams twice a day after mixing with 8 ounces of water. The second was home health rehab with placebo supplements. So the rehab was 3 days a week for 4 weeks. And it's outside of whatever PT or OT that was ordered from the patient's provider. So they could be getting double PT, OT.
Yeah, I'm they could be given PT every day.
Oh, yeah. I wrote in my notes, they may have received a buttload of rehab. So that's something to consider.
Is that your official note?
Yeah. Oh, yeah. I write classy notes. And what I actually really like about it was that they outlined the exercises. They did chair rises, toe stands, seated knee extension with TheraBand, seated rows with TheraBand, and seated arm extensions with TheraBand. Sweet.
Yeah.
The third intervention was home health rehab with legit supplementation. So that's exercise plus the 2 times a day, 20 milligrams of whey protein. Fourth was the single testosterone injection, 200 milligrams for men, 100 milligrams for women within 24 hours after discharge. And the last one is an isocaloric placebo supplementation. So nothing, basically. Twice a day.
As an injection?
Oh, no. That's a supplementation nom.
Oh, okay.
Yeah, the only injection was the testosterone.
Okay.
Yeah, so that was 5 interventions. Supplements, home health with placebo, home health with supplement, testosterone, or just fake supplement.
Okay.
Cool. Any questions?
No, that was very clear.
Cool. The adherence to the supplementation in rehab was over 75%. The adherence with the testosterone shot was 100%, which makes sense.
Because it's one shot. This is, by the way, as working in psych units for a long time,
Yeah.
I can tell you that with a one-time injection every 3 months instead of someone taking meds, is the compliance rate are higher.
It makes perfect sense. It's a lot less work. Okay, so the outcome measures that they used, the primary one was the short physical performance battery. And then they had several secondary outcome measures. One was body composition via DEXA scan and ADLs, but they didn't name a specific outcome measure for ADLs. What they did was they mentioned bathing, toileting, grooming, dressing, eating, IADLs, including using a phone, driving a car, money management, shopping, cooking, cleaning, medication management, climbing stairs, walking a half mile. And then the last secondary outcome measure they used was 30-day readmissions. So they did testing performed at baseline, 1 week, and 4 weeks post-discharge. And then as far as statistics were concerned, they used SAS for their statistical analysis. In general, they used the independent sample T test with intention to treat analyses. With parametric and non-parametric statistical tests, but they only report the parametric because the results were similar. That's it for the methods. Any questions, feelings that you must express?
You know me, I don't express feelings.
You express a lot of feelings, mostly love.
No, I express thoughts, not feelings.
Okay, on to the results. So 100 participants, as mentioned earlier. The average age was 78.1 years old with a standard deviation of 8, which I think is pretty baller.
I like it.
Yeah, 70.
I like it when like the cutoff is 65, but it's not, the average was 66. No.
78.
It was 78.
With a standard deviation of 8. Suckers! I love it. 70% were female, 74% were white, over 90% had a high school diploma, and over 50% had a college degree. So.
Yeah, which we'll talk about it later, but education is one of those things that usually are like a good prognosis when it comes to coming out of the hospital, because usually it's people that are more compliant with the intricate post-discharge instructions.
Yeah, I think that really highlights a limitation of just the Galveston, Texas population and the need for the multi-center study.
Yeah.
So the score for the SPPB was a mean of 6.9, which means a functional limitation. And a score of 7 or less indicates a very big increase in the risk of rehospitalization post-discharge. 74% of the subjects had a score of less than 10. So discharge diagnoses were mostly cardiovascular, like AFib, hypotension. They did say heart failure exacerbation. Also pulmonary, like a COPD exacerbation or pneumonia. And then the third big one was a GI issue, like a GI bleed, diverticulitis, pancreatitis. The average length of stay was 3.1 days. And then they talked about this measure called the Charlson Comorbidity Index, which I don't remember hearing about. But what it does is it predicts the 10-year survival in patients with multiple comorbidities. And it has a cool calculator, a link I'm going to include in the show notes. It's actually really cool. I was playing around with it and thinking of patients that I'm seeing, and it's a number that I'm going to use, actually.
Do you know those, when we were kids, there were websites that you could like predict when you're gonna die?
This is that. Oh my gosh.
This is it, but reliable and maybe
with science.
Yes, but with science.
Oh my gosh. So the link is definitely going to be in the show notes, and it leads to the calculator. You all can figure out when you're going to die.
Have fun.
Have fun. Love SRP.
Happy Easter.
Yeah. So this cohort's mean was 5.3, which indicates a 20% chance of surviving 10 more years. Pretty low. So results for the outcome measures. For the SPPB, there were no differences at baseline. And And then 4 weeks post-discharge, the total SPPB and balance increased in all intervention groups over the placebo, with more people receiving any of the interventions achieving the critical minimally clinically important difference, which is 1 point change or more. So any intervention, they did better functionally. Hooray! Then body composition, nothing, nowhere, not at any point over the 30 days was it changed.
I'm not surprised.
All right, ADLs, nothing.
What?
Nothing at all. No difference.
Even though people that got maybe buttload of PT?
Right, yeah, no difference at all. I mean, they actually didn't differentiate a buttload of PT group. They just said it was a possibility. Maybe if they had, they would have found a difference. I don't know. This multi-center study really needs to address the buttload of PT issue.
Okay, so we didn't help with ADL body composition.
30-day readmissions was highest in the placebo group at 28%, second highest in the rehab plus placebo at 15%. Then number 3 was the whey supplementation at 12%, rehab plus whey at 11%, and the testosterone injection group was the very lowest readmission at 5%.
Okay.
And I wrote,
okay.
Wah, no way.
What?
No way, because it was whey protein, but they didn't have any whey. Ha ha ha. It's a bad joke. It's a real bad joke.
I'm going to blame pregnancy for this joke.
Yeah. If you listeners don't know already, I'm pregnant. So it's fine. My brain doesn't work anymore. It's really annoying.
I didn't know if I should expose this.
That's fine. I mean, we're out on social media, so I don't care.
Also, it's you preparing for mom jokes.
Yeah, I was thinking it's a pretty solid dad joke, but I can't. I'm not a dad.
It's a parent joke. We're trying to be
definitely a parent joke. Yeah, you're right about that. So I was looking at the raw data because they actually make some really nice charts of the raw data. The testosterone group kills it in pretty much everything. Now, it's not statistically significant, but that's kind of amazing. Like, we love exercise. We love nutrition. Like, talk to Patrick Berner, the dietitian PT, about that. But like, this injection of a hormone does better in this study in preventing readmissions than anything else.
Listen, testosterone has great benefits. One of the benefits of exercise is elevating testosterone. That's
true, but this is like just testosterone, no PT, nothing.
But usually one of the effects of testosterone is that you're more energetic, you want to, you are more active. Imagine that instead of making you exercise 4 times a week, there was something that would make, there would be a drug that would make you want to do that.
Yeah, that's an interesting thought. I hadn't thought about that. So, yeah, that could explain it, I think. They found no adverse events, but I will say they did mention that the effect sizes needed to show statistical significance in these things. You need between 64 people and 113, depending on which measures you want to compare. So remember, we only had 100 and it was about 20 people in each group. So as much as I want to say, like, yeah, get your testosterone, get your roids when you discharge from the hospital, we need to wait for that big multi-center study to come through. But still, it's pretty striking. Okay, so that's it for the results. Anything before we go on to the discussion?
No. So far, testosterone is kind of cool, and and we help with readmission a little bit.
Yeah, I would be interested to see if they combine testosterone plus PT and supplementation and see what would happen. If that would just make the readmission rate tank. That'd be cool. Anyway, the bottom line is that In order to prevent hospital readmission, we want to increase muscle anabolism and strength in older adults. Like that's going to prevent them from coming back to us. Effect sizes matter in these studies because we can't identify cause and effect. And these numbers are going to have huge confidence intervals. So this is like a proof of concept sort of study with I just thought it was very interesting results. They say that multi-site clinical trials are to come. And a limitation that they mentioned was that they couldn't include people with cognitive impairment. When a quarter of the people admitted to the hospital had at least mild cognitive impairment or delirium. And everyone was female, white, and educated, and they didn't track the participation in home health. So I think in the future, they're going to pay closer attention to that. Those people getting a buttload of PT. So these interventions appear to be safe and may be efficacious in improving functional mobility and reducing risk of hospital discharge. And that's it for the article. I like your point about testosterone making you feel more energetic. Like I could imagine someone getting home from the hospital and being like, it's time to mow the lawn. Let's plant a garden. Like just doing everything because they can.
That, and even just going back to your usual lifestyle. Like, you know how some people go back from the hospital and for 3 days to a week, they're like, you know what, I shouldn't go and take the dog out for a walk. I just came from the hospital.
That's a good point.
Or I shouldn't go to the end of the street to get my mail. My wife should do it because I just came back from the hospital. And with testosterone, it just makes you. I think that again, this is just a theory that it helps with not only the energy but the ability to do those things.
Yeah, I can imagine people bouncing back much faster if they feel better. Because you're right. People get home and they have friends help them out or family helping them out. And they're taking it easy because they were just in the hospital. I like that point. Thank you for bringing that up.
No problem.
Yeah.
I listen when you talk to me.
Hooray. Okay. Anything else you want to mention? Anything else you want to bring up to the listeners?
No, that was really interesting. I really hope this would be only phase 1 and there would be more phases.
Yeah, I agree. And I believe there's more to come. I think they have secured funding.
It's a really interesting article, and I do think that it's one of those things that... So I get it a lot, and I've been thinking about it a lot. You know how... And whenever you're in PT school or med school or whatever school that you learn about hip falls and hip fractures,
mm-hmm.
you learn that this is the beginning of the end.
Yeah, like so many people die.
And I think about what if we how do we make it not the beginning of the end?
You know, they said the majority of the people in this population were cardiovascular, pulmonary, and GI. And I just realized that so many people we see are orthopedic. Especially
for the acute. For COPD, you see chronic. For heart conditions, you see chronic. So I didn't understand how come they didn't really get any ortho.
Yeah, actually, that's a really good point. I'm looking at the inclusion criteria. You know what I think it might have been? So they needed the ability to stand independently at baseline, but their baseline was defined as hospital discharge. So someone who had a fracture, like a joint replacement, probably wasn't going to be standing independently at baseline unless they had like a super long hospital stay and it was amazing.
Okay. No, okay. I get it now.
Yeah. I'm really glad you brought that up because I like ignore ortho and I know I shouldn't.
No, I like ortho.
Most people do, and I don't.
But also, I had an argument with a colleague, and I said that I never tell a patient this is the beginning of the end because they will believe me.
Of course they will. God, I would never say that.
And or implicate that now there's going to be a deterioration in your function. And he said, so you're hiding the research from them. And I said, and it was about a little bit about ethics. It might be unethical. I do think that we shouldn't tell the patients everything that we know about research. A, it would take a long time.
Right.
B, it's a little boring.
Yeah. But I think that if you were to tell the patient well, you're probably going to die in 6 months. It would become this terrifying thing that could really affect their rehabilitation, and it would become this self-fulfilling prophecy that was completely unnecessary. Yeah. That's I would never tell a patient that unless they said to me, listen, I'm curious about this. Statistically speaking, what does the literature say about my prognosis? Unless they use those words, I'm not going to say that to them.
Those exact words.
Yeah.
And they know what article to send me to look for.
Yeah. When people ask me, how do other people do this sort of thing? I'm honest with them. I say, a lot of people do really well or they don't. And I leave it at that. I just stick with my experience in that regard.
Okay.
Yeah. Well, sweet. Thank you for listening to the Senior Rehab Project. If you've gained from this episode, consider supporting our work. You can become a patron through Patreon, a service that allows people like you to support people like us. You can give as little as $1 a month or become a game changer for $8.99 a month, where you'll get an awesome Redefine Old mug and access to our monthly meetups. Just go to seniorrehabproject.com to learn more and find the show notes for this episode. Talk to you soon.